The only reason you can tell that is because you know what the disc looked like beforehand. Now, what's the evidence show about cup-stick ratios? Okay, let's talk about cup-disc ratios. Here we go. Does that person have glaucoma? How about that? Does that person have glaucoma? That's pretty good. It's asymmetry there. Does that person have glaucoma? Let's look at those again. We're going to talk more about this patient tomorrow. He's an engineer. He has huge discs. He's got narrow rims because he's got huge discs. He has no field loss. I followed him for 20 years. He does not have glaucoma. He hasn't used any treatment. Those are just big cups and big discs. This is a larger disc than that disc there. So the cup here is going to be bigger than that. That's not a glaucomatous disc. How about that? Well, that looks like a healthy disc, doesn't it? But what you don't know is that's what it looked like a year before. So it went from there to there in a year. So this disc here is a glaucomatous disc. The only reason you can tell that is because you know what the disc looked like beforehand. Now, what's the evidence show about cup-stick ratios? Caprioli published it. And of course, the average of a cup-disc ratio in a patient who's normal is smaller than the average in a patient that's not normal. But look at the distribution. Until the cup-disc ratio got up to about 0.8 in his study, you couldn't be sure that the person had glaucoma. Furthermore, the smallest cup-disc ratio occurred in a person with glaucoma. Cup-disc ratios are very inaccurate ways of telling whether a person has glaucoma. They're not diagnostically useful. How about p-values? They're routinely used, but they can be clinically insignificant. Statistically insignificant p-values can be clinically significant, and I'll show you that in a moment. But what is important is what I call an extra threshold value, and we're going to talk about that right now. If you looked at the patients in an ages study and you said, who's going to continue to have visual field worsening? The rapidity of the visual field getting worse was highly significant, 0.001. The amount of field loss was also significant, not as significant, but interestingly, the level of intraocular pressure or the fluctuation of intraocular pressure did not statistically predict whether the person was going to have field loss. So, can we say age is really important and intraocular pressure is not important? No, we can't say that because we think in terms, scientists think in terms of p-values. But let's look at this data further. I took all the patients. These are the patients that got worse, the dark blue bars. These are the patients who didn't get worse. And what I want you to see is that here are the means of the slope, but there was a cutoff. And way above the mean, but there's a point where if your visual field is getting worse more than 1.5 diopter a year, you're going to continue to get worse. Everybody's going to continue to get worse. How about age? Notice the oldest patients didn't get worse. Yes, highly significant difference between the means, but that doesn't tell us anything about the individuals. Age does not predict whether a person's going to get glaucoma or not. What are the two likelihoods that a 75-year-old is going to get glaucoma? What's the percentage? It's either 0% or 100%. They're either going to get it or they're not going to get it. It's not 27% or 82%, which is we keep getting told those sorts of figures. Those are group figures, and you can't generalize from a group to an individual unless everybody in the group is the same as that individual, which is virtually never the case. Now let's look at pressures. Useless, right? Means are almost exactly the same. Very useful. If the pressure is above 35 in aegis, the person got worse. So here's a statistically insignificant thing, and yet pressure is a very, very important indicator of whether a person's going to get worse. Here's very statistically significant, but a useless indicator as to whether a person's going to get worse. We've got to change the way we think about p-values when we apply them to individuals. Now, so that's a pre-symptomatic extra threshold finding, a finding that indicates that the affected person will probably develop troublesome symptoms in the future. These are some extra threshold findings. A superior retinal detachment that's new. A, quote, mole that's really increasing greatly. Within a month, you can see it's great, and then it's changing its shape. An irregular pulse, beating irregularly at greater than 8 beats. That's the sign that person's in trouble. Very interestingly, if a person can't count his heartbeat accurately, he has a short life expectancy. People with body mass over 40, they're sick. They're going to die soon. Serum potassiums, if it's below 2.5 or above, you better pay attention to that. Those are important findings. Now, with regard to glaucoma, there are important extra threshold findings. If the anterior chamber is narrow with a bowing that blocks the visibility of the trabecular meshwork, or if it's still moderately narrow, but you can see the trabecular meshwork, and you can see there's a PAS, and it's bowed, that person's going to have an occlusal angle. That person's going to develop an angle closure attack. When? You don't know. But when it happens, it's going to be a catastrophe. If there's an asymmetry of intraocular pressure greater than 5 millimeters of mercury between two eyes, that doesn't occur in normal people. Sometime along the way, they're going to start developing damage. If they have an afferent pupillary defect, they already have damage. You don't know whether it's due to glaucoma, but you know they've got damage. If they have an acquired pit of the optic nerve, they are damaged. If they have, we talked about that, a mean defect that's valid, it's got to be valid, of greater than 1.5 decibel a year, they're going to get worse. If their rim is getting narrower, one DDLS unit every 30 years, they're going to continue to get worse.